Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, your host for this special series covering the COVID-19 crisis from the front lines. I'm joined by our editor-in-chief, Monty Mythen, straight from London in the United Kingdom. Hello, Monty.
Hey, Desiree. It's all quite eerily quiet.
That's very true. It's eerily quiet, I think, everywhere across the globe, honestly. I think it's been reported from every major city down to every little town. Not many people are out and about, which is an okay thing. Our main mission for this series is to talk to those who are out on the front lines, dealing with this crisis, this pandemic in their own personal practice as healthcare providers. Our next guest is a friend of the Top Med Talk family. She's the director of quality at Providence Anesthesia, Vicki Morton. Hi, Vicki. How are you?
Hi, I'm well. Thank you for having me.
Good. Well, thank you so much for joining us virtually. This is going to be the way of the world for a while, I think.
It is. It has to be.
Yeah. There are many of us in the healthcare world that are used to virtual meetings, so hopefully some things won't be too much of an inconvenience. But really what is changing for us is how we are managing our daily life as providers in the operating room, in the ICUs, and in the hospitals. Vicki, tell us a little bit about your background, your role for your anesthesia group.
As the director of clinical and quality outcomes, and a nurse practitioner with the group, my main role has been historically running our enhanced recovery after surgery program and everything perioperative, implementing programs, educating those, getting everybody on board, writing policies, protocols, pathways, everything related to that. I was told a few weeks ago that everything ERAS would be put on the back burner, and my focus is shifting to COVID preparedness, which did not come as a shock to me at all. So we put together a task force within our group, and we have been night and day, every single day of the week, preparing, writing flowcharts, protocols, checklists, sim labs, dry runs, everything we can possibly do to get ourselves ready and all of our colleagues ready to keep our environment safe for us and for our patients.
That's fantastic. So a huge change for you guys. Vicki, give us a little bit about background about your group.
Sure. So Providence Anesthesiology, we have over 100 anesthesiologists within our group. We also have some APPs, so PAs and NPs as well, advanced practice providers, yes, so nurse practitioners and physician's assistants. And we have mainly within our area 7 hospitals within one health system, and then additional ones outside of the main health system, as well as multiple surgery centers. So we have quite a large footprint, and therefore we have to consider every hospital and their processes when we're creating the documents and the pathways that we are creating to help guide us with the COVID preparedness.
Vicki, can you speak to some of the protocols that you are putting into place? What are you doing for PPEs and training for that?
Sure. So the pathways that we have into place right now, I'll list those first. So we have a C-section, OB C-section flow chart, cardiac surgery flow chart, level 1 surgery flow chart. So these patients that have to get to surgery, we have put on hold any non-essential surgeries right now. The system has anyway. We also have a flow chart for central line placement, for outside of OR intubation, transfer from ICU to OR, OR to ICU, as well as our PPE checklist for the person under investigation and the COVID positive patient. Oh my gosh. Those are the main ones that I can think of right now. We have several others in development, but then also putting together checklists for the healthcare provider wellness, both in the hospital and at home, so that we have guidelines for ourselves, and everybody has to follow those guidelines.
Gotcha.
So Vicki, if we can come back to that component in a moment, if we take you back to those pathways that you put in place for example, for elective cesarean section, is your default mode that the mums coming in may have COVID-19 Is your default? Oh, it is. Okay, so you're doing full PPE for.
I'm sorry. No, let me back up, Monty. I apologize. So it is not necessarily the default now. The standard questions, have you traveled? Have you had a fever? All of the symptoms are being asked, but we are still going to be wearing PPE for all patients. They may not be N95s, but still taking additional precautions. Yes.
So universal precautions, but scaling that up if you think there's a high suspicion, and or if you get into more major testing that somebody in the system has tested, that you will then ramp up to PPE. So that's one of those difficult known unknowns that we're all wrestling with, because there's a lot potentially moving around the community, possibly amongst our patients, but also amongst our providers. And we know there's a limited supply of PPE at the moment. How do we make that judgment call? And I think most of us are doing exactly as you've described.
Yeah, exactly.
We know there is a national shortage of personal protective equipment. What are you guys doing specifically to address that? And how are you handling that with your staff?
Well, first and foremost, we're trying to be very cognizant of the use of PPE that we do have, because we are anticipating that we may one day not have it available to us. So our group, a couple of weeks ago, we collectively decided that we would purchase our own PPE that is reusable. So we purchased enough full-face respirators for all the clinicians, as well as the coordinating filters and multiple filters, because they have a shelf life as well. And we will be distributing those to all of our clinicians, and also have some available to the CRNAs. If we do go into the OR and PPE is not available, then we need to be able to keep them safe as well. So we have done whatever we can, and it's not stockpiling. We only bought enough for all of our clinicians, but we do have over 100. So we had to purchase from multiple sources, and just this week started getting all of them shipped in, and we will now start to distribute them. So we have them. And that will also enable us to free up some PPE to other healthcare providers. Instead of us then using the supply up, we can use what we have, and it frees up the N95s and face masks for others.
Yeah. What are people doing in their anesthesia groups to deal with, a reduction in schedule, but potentially, ramping up to do critical care or step in other places in the hospital? Is that something you guys have talked about or can talk about from your group?
Yeah, we have. So first of all, we do have a pain clinic here. We also staff with our PAs and NPs, the pre-anesthesia testing clinics. And we are now doing all of those appointments virtually. So we're really just trying to distance patients, keep them at home as much as possible, and employ virtual visits. So there's that piece of it. The other piece of being in the hospital, we're really trying to keep non-essential people out of the hospital. So if you are not on call, or if we can minimize how many people we need on in the hospital that given day, then we will do that. Our administrative staff, we have instructed everybody to work from home. So again, just trying to keep everybody as self-contained as possible. And if we have to call in individual people, we are putting together a 24/7 call schedule. So as you know, when you have a case, either a PUI or a positive case, and you've got a whole litany of PPE that you have to don and doff, it's recommended you have a trained observer. So we are preparing those trained observers, and then we will have people on call, including myself, 24/7 to go in and either participate in the case, be one of the observers, be a runner, what have you, and only have people in there if we absolutely have to have them.
Have you seen, people have discussed the possibility of using technology for the donning and doffing buddy side of it. If we went out donning and doffing in turn here and we were watching each other and we're thousands of miles apart, we could buddy up for that. So as we start to get unwell and or have to self-isolate, we're probably going to have to think about that side of it as well. I think some places have done that already, but it's worth remembering that you can buddy up virtually.
I think that's a great point, Monty, and one that I'm going to bring up to our task force, actually. I think that's wonderful.
Well, one of the challenges we have is we have people who now have to self-isolate, so they feel responsible to self-isolate because of where we are in the curve of COVID-19. They're in a household that is now deemed to be infected, and therefore they're supposed to self-quarantine for 14 days. But they're saying, "But I feel well. I can help. Let me help." So some sort of roster of of duties that one can do by using technology appropriately. Just it's good time to think about it.
Yeah, I love it. I think that's a great idea.
Yeah, absolutely. Vicki, have you all been asked as an anesthesia group to start preparing for ICU care? Is that something that you've already started to talk about? And I guess the first question really is, does your anesthesia department cover any kind of critical care units throughout the system that you guys are working in, or systems?
Yeah, so currently we do not, other than, line placement, intubation, if the anesthesiologists are needed in those realms. There has been discussion where it's at currently. I really don't know, but yes, there has been some discussion.
Yeah. Well, that'll be interesting to see how all that unfolds. As the wave comes through, how is it really affecting your all's group? You said you're working on health and wellness, and a lot of people are working from home. What do you think? Kids that or families that have children at home and they're having to work from home. How are you guys dealing with all of those different things?
We're just trying to be as creative as we possibly can, and understand that some people, they are struggling with childcare issues, what have you. Some people we already, we have one of the partners on home quarantine. I just got off. And
yeah,
so
I was going to ask you about your trip.
Yeah.
You recently just had to deal with
it. Yeah. And really, our group, Providence Anesthesiology, they're forward thinkers, and they will do whatever they need to do. And that means taking care of their own first. So whatever has to happen and however we need to change things up to accommodate, they're going to do. One thing that and some people have talked about this, it's about, getting your bed capacity down and also designating units.
Yeah. So are you guys doing that?
Yes. I mean, there's definitely a minimum 85% capacity at all times, and probably even above that at the moment and even the months preceding this. And so there's an effort to get bed capacity down. Shutting down elective surgeries, of course, will help that. But also we are planning with the hospital COVID designated units. So
cohorting your patients?
Cohorting patients, yes. So cohorting the intubated patients versus non-intubated patients, critically ill patients, obviously intubated patients. Also the suspected patients that have not yet tested positive, having a unit there. And not just within one system. They recommend not transporting patients from hospital to hospital. So we're trying to divert as early as possible. And we have, suggested and working with administration about, do we on our smaller community hospitals that can't handle a critically ill patient, instead of having them come into that ER, putting out to emergency services, all of these suspected patients come to hospital A. If they show up in the ER, are they well enough? Can they be diverted off to hospital A? Because if they do test positive, that's what we want them, to avoid any of those transfers from hospital to hospital later in an acute critical situation.
And those great ideas are ones we've heard from our colleagues who are further into this elsewhere in Europe. They haven't necessarily played out everywhere. They're local solutions to local problems, but I think they're fantastic things to be considering. In the last 24 hours or so here in the UK, we've seen quite a transition in thinking from the huge potential burden of the intubated, ventilated patient to the potentially huge burden of the patient that doesn't quite need intubating or ventilating. So there's a live debate about non-invasive ventilation and the CPAP type of technology, which was sort of ruled out a few weeks ago, and now is potentially definitely being ruled right in. We'll know more about that in the next few hours. Not saying that it's right or wrong, but based on other countries' experiences, which could shift that burden into a very different place to the one where we're doing most of our preparedness.
Yeah, I agree. Desiree and I were talking about that earlier. We've definitely discussed CPAP, and of course the thought is let's avoid it because of the, it's an aerosol generating type of ventilation. But if it serves a need and we have to be full PP anyway, then perhaps that is a solution. But yeah, like you said, more to come. I'll be interested to hear more about it.
It's important we all keep talking to each other, and we
Yes.
mustn't do it from the point of view of believing that there's a right and a wrong and someone knows better than somebody else. It's sharing solutions and working out what's right for your own environment.
And I couldn't agree with you more on that, Monty. We have talked to those who have gone before us in Seattle. We've had calls with people from all over the world. I've had multiple text and email conversations with Dan Martin on this, and everybody so willing to share. We have shared our information with those who have asked us. And I absolutely agree that's what it's about. And you have to think outside the box and be able to cope with whatever is thrown at you and think ahead and anticipate. But the more we can share and collaborate, the better off we are all going to be.
Yeah.
Hallelujah to that.
Amen.
So from the community, we seem to be now making a transition from a degree of fear, anger, selfishness into a lot of love coming back into the whole thing. There's a lot of sense of community creeping back in. There's a lot of let's look after the healthcare providers and all the other people doing this. Free coffees being handed out. It's lovely to a certain,
Yeah, we're seeing that here as well. In fact, this morning I was reading something on my email. It's a community email, and somebody had suggested at 7 p.m. tonight, in effort to comply with social distancing, everybody sit out on their driveway. And at 7:10, somebody's going to play loudly "God Bless America." Aww. And then after that, I think it's some song about a happy dance. I can't remember what it was, but just to get everybody outside and to be able to say hi to your neighbors and still comply with what's being asked of us.
So are they starting to do testing for patients? Are they lifting some of the restrictions that were initially seen?
Yeah, they are doing drive-through, drive-up testing. There are several sites around the city. However, the screening is not loosened up, and I really wish it would get tested.
Because you were recently tested for COVID, right?
I was in Italy for 10 days, and I came back and was self-quarantined and got sick, got a little bit ill, and went and got tested. I'm negative, so that's wonderful news. But initially, when I came back, I wanted to preemptively get tested. I'm a healthcare worker, came back from a hotspot, wanted to get tested. And they said no, because I wasn't exhibiting any symptoms. But we all know that even positive patients don't necessarily have symptoms. But it wasn't until I had a temperature and I had various symptoms that they said, okay, we will test you. But if I didn't have all of those symptoms, they still were not going to test me. And I think that that's a problem. I think we need to be opening it up. And I realize that test kits are limited. We have to be careful. But I also think we have to be smart about community spread, and that a lot of these people are afebrile. Many of them are asymptomatic, and they are now out there in the community spreading the love when we could have maybe identified them early.
Exactly. I mean, the testing most places now is coming at scale and pace. I think that various different countries have been in a denial, different types of denial, phasing, timing. And as everyone gets over the denial component of it, the testing's ramping up quickly.
I hope to see that here very soon.
Yeah, I hope to see it as well, because I don't know if it's really ramping up in the areas that aren't seeing the high number of cases as, are the states on either side of the country.
I mean, it's got to be deployed rationally and sensibly and as it becomes available. But I think its availability will change quite significantly. It just doesn't mean everyone will be tested at a drop of a hat.
Yeah.
But part of our decisions about testing has been limited resource. So that's changing.
Yeah. Our positives are doubling almost daily. So we definitely more people are getting tested, which is fantastic. And I hope that there's some more availability as the days proceed.
Your husband is a pediatric intensive care physician, right?
Yes.
Yeah. So what is his view on all this? And is he seeing patients come in?
Yes. So they are. Thus far in the peds ICU, they have tested negative, thankfully, but seeing critically ill kids. And they're planning just as much as we are. He's been on just as many conference calls as I have been on. I feel like I've barely seen him over the last couple of weeks. And they are having to readjust their staffing as well. And they're going down to the bare bones. Typically, they have two people, two intensivists on at all time, a primary and a backup, and they're getting rid of a backup. Backup is only called in now for very specific criteria to preserve as much as they possibly can. So yeah, they are in planning mode as well.
You have been the lead for your enhanced recovery programs there at Providence. And, you just said that's all been put on hold. Some of the conversations that Monty and I are having is that we know we are still going to have to do surgeries. And some of those surgeries may be cancer, surgeries for cancer and, hearts, things like that, where we still need to be doing ERAS. And in fact, now is a better time than any to start instituting those because, we want to make sure these patients are fit for surgery, that they get in and out with the least amount of complications possible. So have you guys talked about that within your group?
Yeah, sure. And so let me clarify. When I say my focus is diverted, the program still runs. The program is a well-oiled machine, but my current expansion of the program and various meetings and things like that are being put on the back burner. We are still having the patients that need the surgery, that are ERAS designated surgeries, getting their education virtually. So either a kind of a Zoom like this, or just on the phone, what have you. They are still able to come by and pick up their carb loading, drinks, and we're still doing everything that we would normally do. It's just the way in which we're doing it has changed. So the program is not on hold.
The back burner expression is perfect. It's simmering on that back burner at the moment, still doing a job, working away. And at the moment, we're in the front, it's under full flame for this preparation. But it's not going to be long until that pans back on the front burner because, and more so for institutions, unlike yours, that haven't really got going with enhanced recovery yet. What tremendous opportunities to accelerate the adoption of those principles and keep people out of ICU, get them home quickly. It should be a win-win-win-win-win-win-win, which it's gone up.
Yeah, I agree with that. And it'd be great if places could simultaneously, if they don't have a program, start getting it up and going. If they have people that can focus on that and then separate people focusing on COVID, that would be fantastic. We're lucky in that we have a very well-established program in all of our facilities. But right now, just bringing on additional surgeons and service lines is going to happen a little bit slower.
Yeah. So. I think now it's a great opportunity for some of those people that are not, sitting at the front line right at this exact moment in time. So some of those surgeons that have had to back away from their elective cases, nurses, extra staff, to start doing a little bit more research and learning a little bit more about it so that they can, possibly start instituting it, at least, components of it. It's a great time to bone up on all your educational things.
Patients are going to need it, that's for sure.
And if you want all the information, if you want to have order sets, if you want to have everything that you think might take you weeks and committees, it's 3 clicks away. It's all free. It's all on the internet.
Yeah.
You just got to be prepared to not think you have to reinvent it for your own institution. They all end up reading the same. I haven't seen anything around the world. There's a few interesting spelling differences. But aside from that, they're all almost identical.
They really are. They're all very, very consistent. So it can be plug and play if you're willing to do that.
Yeah. Hey, Vicki, one thing that I want to make sure that our listeners have, I know that you said that you are collaborating with people across the world. And so if someone wants to get a hold of you or in touch with you to connect with you, what's the best way to do that?
Well, probably shoot me an email. So my email is kind of long, but I'll spell it out. Well, I don't have to. It's Vicki, VICKI, .Morton, MORTON, @provanesthesiology.com.
Great. And you're also on social media, so they can.
I am on social media.
Find you on Twitter, Facebook.
Yeah, Twitter, LinkedIn, Facebook, message me, what have you.
And we put all of that in what we call the show notes. So if people are new to Top Med Talk, if you go into the podcast and you read the bit below, the team will put in there that email address. So thanks, Vicki. That's very generous.
Well, thank you for having me, and thanks for doing this, because as I said before, communication, and Monty said it, communication is key. And the more information that you can get out to everybody, the better. And really appreciate what you're doing. It's helped us. I've listened. It's been helpful.
And good luck to everyone tonight with their street
Yeah.
I'm guessing it is probably Pharrell Williams with Happy.
Yes, that's it. Yes. I'll be social distancing on a boat in South Carolina. So
if you put your address in as well, people could swing by and pop up their chairs and tables and sing along Happy to them.
Sure, I might have fun music playing all the time if you do.
Good luck with that.
All right, Vicki, thank you so much.
All right, thank you so much.
Good luck. Stay safe. Thanks for all your work.
You as well.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.